The finger contact is very light, sensitive, and delicate. When a sacrum is locked and there is very little motion perceivable, the fulcrum you provide with this contact can be very effective in helping the bone to reorganize and balance. With this hand position, you can really sense all the variations of movement within the sacrum. The next technique is the sacroiliac decompression. Slide your right hand under the sacrum. When that contact feels firmly established and you feel relaxed, place your forearm across the iliac spines. The part of your forearm closest to the elbow rests on the right iliac spine. Your fingers contact the left iliac spine. Your sensitivity will be greater if your contact is light and focused. Extend your awareness into the ilium, the ischium, and the perineal floor, as well as the symphysis pubis. Try to feel the bones move under your forearm and fingers as they harmonize with the sacrum. It will help if you synchronize your breath with your clients. There are two possible intentions for this technique. The first is to track the motion and wait for an unwinding to occur. The second is to apply a light compression on the ilium toward the midline, which will gap the iliosacral joint posteriorly. This is a great technique to do if the sacrum is stuck and you are having trouble feeling any movement. The key to doing very effective work is to be able to be still and focused enough to differentiate patterns of restriction. As you begin this work, be patient with yourself and know that your focus and stillness is facilitating healing in your client. The next technique is the core link. Staying seated with the right hand cradling the sacrum, move your left hand to cradle the base of the occiput. Remember that the dural tube has attachment points at S2 and the foramen magnum. Sit and monitor the rhythms of the sacrum and occiput. You are providing a fulcrum through which these two poles can reorganize their rhythms and communicate clearly with each other. Notice the amplitude, rhythm, and speed of the cranial wave, and see if you can tell if there is any restriction in the sacrum or occiput. Keep your breathing deep, relaxed, and rhythmic. In all of these sacral techniques, the intention is to bring harmony and balance into the cranial rhythms. The client's body wisdom will do the rest. If the sacrum wants to unwind in any of these holds, follow the movement of the client. Do not lead her. Give her permission to move with your intention. You don't necessarily need to say anything. There may be times when a soft word of permission would be appropriate. Once the movement of unwinding starts, just be with it, as you would be in a contact dance. Be respectful and follow her lead. Quiz, question 1. Medial compression to the ilium is intended to A. Release the lumbosacral junction, B. Release the sacroiliac joints, C. Release the dural tube, D. Free the cranial base. The correct answer is B. Release the sacroiliac joints. Question 2. Restriction in the sacrum can affect the cranium because A. The sacrum is located in the cranium, B. Restriction can travel through the lumbar discs, C. The dural tube and cerebrospinal fluid impact the cranium, D. Sacral restriction leads to piriformis syndrome, referring pain into the cranium. The correct answer is C. The dural tube and cerebrospinal fluid impact the cranium. Question 3. During flexion, the apex of the sacrum moves A. Anterior, B. Posterior, C. Lateral, D. In a circular pattern. The correct answer is A. Anterior. Lesson 5. The occiput. The occiput makes up the posterior base of the cranium. It articulates with the parietal superiorly at the lambdoidal suture, the temporal bones laterally, anteriorly with the sphenoid at the synchondrosis, and inferiorly with the atlas. The foramen magnum is the space through which the spinal cord moves, surrounded by the dural tube. On the inside of the occiput, the falx cerebri attachment creates a ridge here, and the tentorium cerebelli splits and attaches to these two ridges. These ridges attest to the powerful force that these two membranes have on the occiput. Because of these powerful attachments, the cranial wave is very accessible while touching the occiput. According to the osteopathic model, the occiput swings around a transverse axis. During flexion, it moves like so, and during extension, it moves back. The occiput moves in concert with the sphenoid, and the spheno-basilar joint is very important. According to Hugh Milne's liquid electric model, or the opposite motion model, the occiput can also move laterally. As the tentorium flattens when the temporal bones flex, one side of the occiput moves slightly anterior and lateral. Then, as the opposite side of the tentorium flexes, the other temporal bone moves anterior and lateral, bringing the other side of the occiput anterior and lateral. Clinically, the most important thing is that the distance, rhythm, and intensity of movement is balanced, whether you're tuned into the lateral motion or the midline motion. Cranial base release. The purpose of this technique is to release the soft tissue attachments to the cranial base and free the movement of the axis in relationship to the occipital condyles. If you perform the lumbosacral decompression, make sure to include this technique. Start by positioning the top of your client's head one hand's length down from the end of the table. Cradle your client's head in your hands and contact just inferior to the occipital ridge with your finger pads. Lift the client's head by straightening your fingers as much as you can in an anterior direction, allowing the weight of your client's head to rest on your finger pads. As the client relaxes, the weight of their head will fall more into your palms, and your fingertips will penetrate deeper into the suboccipital space. When your fingers begin to feel the posterior arch of the axis, apply light traction in a cranial direction with your index and second finger, while your ring finger guides the axis in an inferior direction away from the occiput. The client may experience a feeling of floating. This is good. Sometimes while monitoring the occiput, you may experience the side-to-side motion as being very exaggerated. Often it feels like the bone is moving inches out to one side. Of course, the bone really isn't moving that far, but it really feels like it. If this should happen during your work, just sit and hold and monitor the wave. It may take a long time for the flexions and extension patterns to normalize. If they don't, then you can assume that this client needs more help than you can provide. Know when to refer to a physician, especially if a client has come to you with severe symptoms. Fourth ventricle technique, or CV4. This is a profoundly relaxing technique that enhances cranial rhythm function and improves lymphatic flow throughout the body. Because of the direct connection to the falx cerebri, the falx cerebelli, the tentorium cerebelli, and the dural tube, freeing the movement of the occiput can have profound effects. Dr. Sutherland and others have said that this is the most useful of all the cranial techniques. This technique alone has helped relieve headaches, reduce fever, assist in a difficult labor, relieve congested sinuses and lungs, and reduce edema. It's also good to reduce trauma, as in a whiplash injury. It activates the parasympathetic nervous system, resulting in deep relaxation. As a caution, if a client has high blood pressure or any other disease that involves an imbalance in the arterial or venous system, this or any other compression techniques are inadvisable. Start with your hands palm down on the table next to your client's head. Then, as your client exhales, rotate your hands and position your hands so that her head rests securely on the thenar eminences of your palms. Your fingers are cupped and both thumbs are at the side of the neck. Your thenar eminences will be able to monitor the cranial wave of the occiput as it moves into flexion and extension. An optional thumb position is to have the thumbs in a V shape. Whichever thumb position you use, the most important thing is that your thenar eminences rest on the occipital bone. Track whatever movement you feel. Sometimes there will be spontaneous still points where a particular movement will stop for a few moments as it reorganizes around the fulcrum provided by your hands. Just be present to the process. The movement will begin again, perhaps in a different rhythm. You will notice that the motion of the occiput mimics the motion of the sacrum. This is because of the two large attachment sites of the dural tube at S2 and the foramen magnum. Working with the occiput actually completes the work that you just did on the sacrum. The occiput is also an excellent bone to help facilitate a still point. To encourage a still point, track the occiput as it widens in extension and gently resist its motion. The pressure is so light that it is really more of your intention than actual pressure. You will feel the occiput wiggle or shimmy against your thenar eminences and then relax into a still point. When the body is ready to come out of the still point, you will feel the occiput gather itself together and bloom into flexion, accompanied by whatever corrective motion the body needs to make. Do not maintain this hold for longer than 10 minutes at a time. If your client begins to move her head or starts to unwind her neck, follow her. You can gently move her head off the end of the table as you support it with your hands. Then she can unwind freely. During any unwinding, you may need to shift your position to accommodate and support her movements. When you feel satisfied with the movement and sense that the reorganization of cranial rhythm is complete, gently release the hold, being careful not to jar your client. Quiz. Question 1. Which part of your hand contacts the occipital bone during the CV4? A. The thumb tips. B. The hypothenar eminence. C. The palm. D. The thenar eminence. The correct answer is D. The thenar eminence. Question 2. Don't perform compression techniques on clients who have A. Diabetes, B. High blood pressure, C. Sinusitis, D. Headache. The correct answer is B. High blood pressure. Question 3. The purpose of the cranial-based decompression is to A. Loosen the suboccipital muscles, B. Free C1 from the occipital condyles, C. All of the above. The correct answer is all of the above. The sphenoid is the keystone to the skull and provides the rhythm for the other cranial bones. Both the falx and the tentorium attach to the sphenoid. The sphenoid nosedives during flexion, then pauses and reverses this motion in extension, creating a lazy 8 pattern. In the opposite motion model, each wing of the sphenoid alternately moves into flexion. The sphenoid and the occiput are joined at the sphenobasilar junction. It is because of this sacrum-occiput-sphenoid connection that clients will frequently feel their sinuses clear or experience some other sensation in their head while you are working on their sacrum. The pituitary gland rests next to the sphenoid. If the sphenoid is compromised in its motion, it can affect the pituitary and the entire endocrine system. Check the sphenoid for restriction when clients have headaches, sinusitis, back pain, learning disabilities, temporal mandibular joint dysfunction, or vision problems. Our first technique is the sphenoid release. Sit at the head of the table and lightly rest your fingers on the occiput. Place your thumbs over the wings of the sphenoid bone. As the sphenoid is halfway between flexion and extension, very gently encourage the greater wings to move posterior or towards the table. This motion compresses the sphenoid towards the occiput. Hold the sphenoid in compression for a few seconds until you feel it start to gather energy or ask to be decompressed. Now with your thumb pads, gently guide and encourage the greater wings in an anterior direction or towards the ceiling. As you feel the sphenoid float upwards, you will notice a freer and larger cranial rhythm. This is the basic technique. The next step is to evaluate for specific motion in the sphenoid bone by encouraging motion in the following directions: flexion, extension, side bending, torsion, translation superior and then inferiorly. If there is an obvious sense of ease in one direction and bind in the other, then you have discovered a lesion. To correct this, guide the bone into the direction of ease and then follow the inherent motion. Coronal shear. After performing the basic sphenoid technique, you may want to listen more deeply to the bone, especially if you have noticed a movement pattern that seems irregular. If the sphenoid seems to be stuck or severely compressed, use the coronal shear technique. It is one of the most effective techniques to sense the movement in the sphenobasilar joint. This grip frees the coronal suture and facilitates motility in the sphenoid and occiput. It is used most often to treat and monitor severe trauma which result in a compression lesion. A compression lesion is felt as no movement. This lesion is the most dysfunctional that can be felt. If your client has been in an accident or has had a blow to the head, she may have a compression lesion or vertical and lateral strain. You will need a finger cot for your little finger or a glove. Place these on your right hand. Cradle your client's occiput in your left hand. Hold for a few minutes to begin feeling the cranial rhythm in your hand. Allow your client to settle into this hold before you engage your right hand. Have your client moisten her lips and open her mouth. Slowly and gently slide your little finger along the outer surface of her upper teeth on the left side of her face. Place your middle finger on the greater wing of her left sphenoid, your thumb on the right wing of sphenoid, and allow the hand wedge between your thumb and index finger to rest near her third eye. The grip is light and gentle. This technique can be done sitting or standing. Just make sure you are comfortable and are not straining your neck, shoulders, and arms. Feel for motility and listen deeply for movement. Are you feeling and sensing a flexion or extension? Is there a torsion pattern with one of the wings moving more easily and further up than the other side? Or is there a side bending pattern with one greater wing moving more easily towards the front of the head? If your client is in chronic pain, there may be a lateral strain, which you will sense as an out-of-sync movement of both the sphenoid and the occiput. There may be a vertical strain, which might be felt as if the sphenoid is moving up and away from the occiput. Even more severe is a lateral flexion, which feels as if the sphenoid and occiput are both moving together up and away. Finally, the most severe strain is the compression head, which may feel stuck. There is no movement or severely limited movement. Once you have listened and felt and assessed the lesion pattern, you can release the hold. Possibly your presence here has awakened your client's inner physician, and this technique has helped correct the lesion pattern. The next technique is Sutherland's grip. Your intention is to energetically decompress the viscerocranium off of the neurocranium. This technique is wonderful for sinus headaches, jaw tension, and any feeling of physical or emotional compression. Again, place a glove on your right hand or finger cots on your index and middle fingers. Place your left hand over the greater wings of sphenoid with your thumb on one wing and your middle finger on the other wing. Ask your client to moisten her lips and open her mouth. Gently slide your fingers along the bottom surfaces of her upper teeth to the back tooth. Your intention is to lift the maxilla up towards the sky away from her frontal bone. So the angle of your grip is important. Make sure you are lifting up and also pulling down towards her mandible at the same time. Imagine her maxilla being freed from the frontal bone. Create space in her sinuses. Many people with chronic sinusitis have maxillas that are jammed up into their vomer, ethmoid, and frontal bones. Visualize creating space and energetically separating her viscerocranium from her neurocranium. Hold and listen to her teeth dance and talk to you. Feel their rhythm and watch them relax and open. When you feel the rhythm shift into a harmonious pattern, gently release her teeth and then let go of her sphenoid. Lesson 7. The temporal. The temporal bones are located on the side of the cranium and are connected to the sphenoid, parietals, occiput, zygomas, and the frontal at the pterion. The mandible articulates with the temporals through the temporomandibular joint. There is an attachment to the tentorium cerebelli on the inner surface. The movement of the temporals is complex, but the standard model has the squamous portion moving laterally and the mastoid portion moving posterior and medial. One bone takes up the slack in the tentorium cerebelli while the other bone gives out slack. Then they switch. Stay open to whatever motion you feel in your client. When a client has vertigo, dizziness, or generally feels out of sorts, look to balance the temporals. The facial nerve moves through the temporal bones and can affect Bell's palsy and other numbness and neuralgia symptoms. Monitoring the rhythm of the temporals will give you a good idea of how the sphenoid and mandible are behaving. If the temporals feel out of balance, there's a good chance that the sphenoid is torqued and the mandible is locked, causing painful symptoms of temporomandibular joint dysfunction. The feeling of a healthy, relaxed temporal bone is that it feels elastic. It is as if when you contact both temporal bones at the same time, you feel a rhythmic, elastic pull. Ear pull decompression. Contact each ear with 3 fingers. Place the thumb inside the ear and place your index and middle fingers outside the ear, establishing a firm yet gentle contact. Hold and become still. Monitor the cranial rhythm. Notice if one side feels stuck or restricted, or if both bones are moving freely. Clients who have tinnitus, TMJ dysfunction, or vertigo, particularly after childbirth, will usually have one temporal bone in a stuck or compromised movement pattern. You can relieve these conditions by decompressing the temporal bones. Slowly begin to decompress by pulling the ear back and down at a 45-degree angle to the table. As you are pulling, make sure you stay in full contact with the cranial wave. Keep your attention focused. Here again is the fulcrum you are providing. Visualize the horizontal elastic tent of the tentorium in your mind's eye. See the moving of this membrane and feel the elasticity under your fingers. You will feel the tentorium moving back and forth as it goes through flexion and extension, unwinding the lesions that may be causing headaches, tinnitus, nausea, and other pathological conditions. Palming compression. Place your palms completely over the ear. Have your thumbs covering the sphenoid area and the zygoma. Your little finger is in contact with the occiput. Your palms are over the ear with a very light yet firm contact. Apply subtle compressive force. This softens the tentorium, allowing freer motion of the temporal bones. Close your eyes and be still. Wait for movement. It is very subtle and yet pronounced. As you feel and connect with the membrane quality of this contact, you will feel movement emerging, as if coming out of a fog. Begin to discern distinct movement as you feel the temporal bones dance and breathe and relax. Feel here how the temporals communicate with the mandible, the sphenoid, zygoma, and frontal. Fine-tune your perception so that you can mediate a balanced rhythm. Your client's breathing will become deeper and more relaxed as she surrenders to this new rhythm provided by your fulcrum. Be patient with the changes. Get quieter and quieter inside, and you will be rewarded by a lovely symphony of movement. Quiz. Question 1. Which part of the reciprocal tension membrane connects to the temporal bones? A, the tentorium cerebelli, B, the falx cerebrum, C, the falx cerebellum, D, no connections. The correct answer is A, the tentorium cerebelli. Question 2. Balancing the temporal bones can help A, vertigo, B, back pain, C, chest pain, D, upset stomach. The correct answer is A, vertigo. Lesson 8, the parietals. The parietal bones make up the top of the cranium. They connect with the frontal bone anteriorly, the occipital posteriorly, and the temporal bones laterally. The falx cerebrum connects directly to the underside of the sagittal suture. On flexion, the parietals move inferior, become wider, and move slightly anterior. On a spiritual level, the parietals are where our crown chakra is located. The parietal hold and lift. The purpose of this technique is to free the sagittal and squamous sutures and release any tension in the falx cerebelli. Step 1 is to place your thumbs lightly on the crown and your fingers at least a ½ inch above the top of the ear. Feel the movement of the cranial wave under your fingers. Once you get in tune with the cranial rhythm, step 2 is to apply gentle medial pressure with your fingers and wait for the temporal sutures to disengage. This may take several minutes. You will feel a slight softening under your fingertips. Once this occurs, step 3 of the technique is to allow your thumbs to move away from the skull as your fingers apply gentle traction in a superior direction. On an energetic level, pull the parietal towards your open heart as you move into compassion. Closing your eyes or moving them into a very soft focus can facilitate your allowing the parietals to energetically move through your heart space. This technique induces peace and tranquility and is very helpful for clients who have vertex headaches or are easily angered. When you have reached the end of the range of motion, gently hold until you feel a further softening, and then follow the parietals as they settle back down next to the temporals. Complete by releasing your fingers. Lesson 9, the frontal bone. The frontal bone forms the most anterior portion of the neurocranium and separates it from the viscerocranium, which are the bones of the face. Its most superior portion is at the bregma, which is the junction of the coronal and sagittal sutures. In Eastern spiritual traditions, the bregma is the point of the crown chakra, where we connect to God. The frontal provides a wonderful place to center ourselves and access our higher centers. The falx cerebri connects to the inside surface of the frontal bone, and through the pull of the falx cerebri, force is transmitted between the frontal and occipital bones in an anterior-posterior direction. Long-term strain can cause the fibers to reorient themselves, setting up a dysfunctional motility pattern. Techniques on the frontal bone are designed to reduce strain on the falx cerebri. The osteopathic view of frontal motion is that in flexion, the falx cerebri pulls on the frontal, flattening out the center. Other possible motions are rotation.